किया हुआ सर, सेटिंग्स मैंने चेंज कर दिया सर. नाउ आई एम co-host. आई हैव चेंज्ड द
Sir,
सेटिंग्स.
can we start now?
Dr. Andrew is there.
Sir is there.
So he's
We make Akansha also co-host.
Yeah.
so
Okay,
Shamsi,
sir.
Dr. Andrew is muted.
Andrew sir, please unmute sir. Yeah. You can. Aradhana, please unmute.
Sir, can we go live?
Yeah, you can go live and please make
Yeah.
Akansha co-host.
Yeah.
Yeah.
Yeah, sir, done. We are going live in 5 seconds, sir. 5, 4, 3, 2, 1. Sir, we are live now.
Hello, everyone. I'm Dr. Rajat Agrawal, President Asami, India, and welcome again to our great webinars, the monthly webinars, which Asami, India hosts. And every month we keep a theme for everyone to learn something more. So I was thinking that whenever any young surgeon starts Ilizarov, what he does, first he puts a frame, that's the method of Ilizarov, then he does a corticotomy, and then he tries to avoid the complications and the mistakes. So this is the theme of our today's webinar. We'll be learning the method, we'll be learning the corticotomy techniques, and we'll be learning how to avoid the complications and the mistakes. So with this, I hand over the screen to Dr. Shamsul, our secretary, so to have a brief about our faculties, and let's start their presentations. Shamsul, please.
Thank you, sir. Good evening, everybody. We welcome you all in our next series of Assam India Master Series webinar. So today's theme is the Ilizarov basics, and our first faculty is Professor Andrey Kaminsky from KURGAN. Then we have Professor NOVIKOV from KURGAN, and then we have Dr. SATISH NESARI from BELGAUM, and we have other persons from Karnataka for case presentations. So about Professor Andrey Kaminsky, he's from KURGAN, Russian Federation. Special statement is a senior researcher of the Endoprosthetic and Arthroscopic Reconstruction Laboratory, based on platform of Russian Ilizarov Scientific Center for Restorative Traumatology and Orthopaedics, the Chief of Trauma Department since 2005 and Lecturer of Study Department since September 2016. I have essential professional skills and knowledge in such areas as endoprosthesis, replacement, arthroscopy, and osteosynthesis. Education is done in 1993 from Human State Medical Academy, had been involved in science and research activity and gained different work experience during studies. From 1996 to 2016, he has in RISC RTO, completed dissertation of Ilizarov external facet treatment of middle-aged and young patients with hip fractures. In 2013, he did from Tom's Gates University of Control Systems and Radioelectronics as professional retraining health management certificate. In 2016, he has done his financial university under Government of Russian Federation, second professor degree, state and municipal management. Employment from 1996 has been a trauma specialist at the Trauma Department of Emergency Care Hospital in KURGAN. From 1966 to present, he is at Russian Ilizarov Scientific Center for Restorative Traumatology and Orthopaedics. Since 2005, the Chief of Trauma Department at Russian Ilizarov Scientific Center for Restorative Traumatology and Orthopaedics. Since 2018, he has been the head of Bone and Joint Reconstruction Surgeon Clinic for Children and Adults. Regarding science and research, he is lecturer of Dupuy Smith and Nephew Matthews Education Programs, 5 patents and 21 innovative improvement suggestions, more than 50 national publications, participant of different international and local endoprosthesis forums. He is the head of internship programs for young doctors in Russian Ilizarov Scientific Center. Society's membership is a member of AOS member and Asami member. Practical work, the spheres of practical interests are very diversified and cover field sites: knee, hip, shoulder, elbow, and ankle prosthetic replacement. The RISC RTO Trauma Department performs more than 200 surgeries per year, including revision, reconstruction, and endoprosthesis in complicated cases. With this, I request Professor Andrew to present his talk, sir. So, would you like to present your screen, sir?
Thank you, Shamsul. Dear colleagues and friends, I'm very grateful and proud to be able to speak in Assam, India. Just want to apologize my English if I get confused, forget words, and really hope for the help my great friend, Dr. Barry. Thank you, and let's go. Now we'll speak about Ilizarov methods and the only basis. I see these cases you show in the Asami, India. It's a very difficult case, and I understand this know about these basis principles and basis and Ilizarov, but repeat is the mother of the law. And I do it's the way maybe the little things it's useful for you. And the first position, the Ilizarov method is not same the Ilizarov method. The Ilizarov method is a complex, is ideological and technical option for using many combination of the limited number of device parts that solves any orthopedic problems. There are many similar fixators, and after fighting for the principle, primacy of the invention, but no one went further than the device and did not offer the methodology of treatment of bone pathology. And for example, this the next construction. It's this many. It's we can see the ring fixation and the 1936 and the fixation wires or rods in the ring and the same, and these the same the apparatus, Ilizarov apparatus and the ring supers already very similar. And these were born in the Ilizarov apparatus in 1951, and the future copy and carried out with this mirror design changes. These one, and instead the holes into the grooves and the polygonal supports and the combination mechanical device and computer technology and restore the axis and segment. And the Taylor apparatus the same, and the next complex reposition junction. But the second provision, the methods maximally reveals of orthopedic defects and deformities and treatment of infection. In trauma, it's used possible, but maximum effectiveness in difficult situations and multi-community, crushed fraction, open fraction with fused defect and temporary fixation. For simple case, they used in internal synthesis is more just. My scientific work more than 20 years ago was about the treatment of peritrachanteric fracture using the Ilizarov method. Very few people today would risk doing such an operation with available modern means of osteoarthritis. But then it's impossible to use all other methods of treatment within the walls of our center. At that time, it was good for development of the methods and such for the limited of the application. But today we must think about our patient. Therefore, simple diaphysis fracture can be treatment with the Ilizarov method, of course, but the intermedullary nail would be better method. And the proposition 3, mastering the Ilizarov fixation looks simple and often does not give the expected result. But mastering the Ilizarov method is complex and multilateral progress that always give a good result. And we can see the picture, the many options and many technologies and orthopedic and pelvic surgery, bone oncology, and veterinary, and cranioplasty, and spinal surgery, and traumatology, and other. It's multilateral movement. What about apparatus? It's important to understand. There are few details of the Ilizarov apparatus, but the potential for these is unlimited. It's like Lego, and the little people in it of our patient can be. These apparatus, it's old apparatus, but with the same all the details. The prefabricate supports to use more comfortable. Also, it take longer to assemble. And the support assembled from the half rings with possibilities are only limited by your imagination. Open support, it's very useful for the more joint option and the move in this. Arcs, it's the pelvis and the proximal femur and the spinal. Wires, we can see this wire with super platform and the oliva and other chaperone. Wire fixed. The frame fixed is the all fixed and this rarely used, and the bolt fixer and the bolt with slot is the main of us. The tightening wires, we can see we can tighten wires with the key, but better do is with special tensionational device. And another option, the fix wires in the rod at hole and the slot. And this picture, we can see the ring and the fixation wires on the ring or in the bracket. Screw rods, it's different construction and self-taping, shaping, and rod screw can be instead in the metaphysical bond without ring. It's no problem, but the dephysal bond ring is the essential element prevent fracture and insertion. And this special device for it. And rods screw fixation, it's special, but the simple bracket fixation. The rod fastering method is another. It's brackets and the holes and the two brackets and other lines. Connecting elements is the serrated rows and telescopic rows connect its roads, so we can very late on the construction. And the next connection element, load bearing functional elements for proximal femur, and of course bolts and nuts. Without bolts and nuts, we haven't Ilizarov, that's all. Additional element, the salts, and this use case for the special, they change the rings for use these elements, and another variants, and we can the big and strong elements beams can perform to function by an elements fixing and the additional brackets for use with serrated holes at go, but bolt and boy and we say give me boy for 2 and go for 3 also. And the brackets, it's multifunctional element. And for fixation of the wires or fixation of the rows with wires and the special device, the rotation device and the hinge and the other. You can make multi-plane hinge for several brackets. Another this is bushings. It's the connecting elements and the special fixation for the angle and other variant. Very important device is the with the slot is the secant scene and the slot for fixation on the road with these washers and the use independent means of fastering the wire and compensate of inaccurate feed the wires to the super. And you can see. And next is the conical and spherical washers. Is usually used to part to fasten elements and then. Well, this example roads spherical washers and these rings in the angle on the another. Another topic, rigid or fixate of rules managing bone frame. What the main resources associated with this is the dynamism and the ability to manage and control the change. What is the realization? Structural rigidity. Rigidity of the wire fixation. I'm sorry. The rigidity of the wire fixation, the greater part of the bone. In increase the size of the ring leads to increase in the length of the wire outside the bone, and the rigidity of fixation decrease. And rigidity fixation depends on the tension of the wires, the length outside of the bone, the number of the wires of fixation directly, and support on the brain. When the wire cross 19 degrees, the support occurs uniform stability. Such a crossover really achievable, but we have this position. Usually there is acute decussation angle and obtuse one. And what about the support of less stable under the action of the overtune force in the ligament of the obtuse angle, and the larger this angle, easy the displacement occurs. The placing of the rods at some distance from the support significantly increase the rigidity of the fragment fixation. It's better to take out of the direction of the zone of interest, shortening the lever. And very important moment for structural rigidity. The tension of the wires fixed on the bracket deforms the angle of the support. And weakness the tension of the wires turn. And necessary to remember this is check the tension during the final installation. If you use the another ring fixation additional wire, the ring does not affect tension of the wire in the body support and creates condition for level of the rigid fixation, work as element for a position. But it's not always possible to use with the short fragment. Let's understand terminology. A support is the rings, half rings of arc wires and or rod screw fixed in it. Reinforcement elements, wires and rod screw fixed on bracket and console maybe. The system is the whole structure of the apparatus. The subsystem is the support of or supports with the reinforcement element like as on the one bone fragment. A working subsystem, when restoring access the segment, place the distal fragment along the proxy. And each situation, one should single out the proximal and distal subsystem and work in them to solve the local problem. And this picture we can see is the one subsystem and two subsystems. Between it, the zone of interest. This may be one subsystem, two subsystems, and this one subsystem and two subsystems. And this problem we disease in the between the subsystems. The movement, the length, width, and angle along the peripheral, rotational, and combination. Moving fragment along a leg, it's no problem with traction and compression. It's carried out by roads, can be simulation, and but not simple is moving fragments width. Reposition by moving subsystem by installed road and angle. And maybe installation reposition system and the road and the brackets and reposition due traction transverse elements and the tension pre-curve wires and the pull wires with the olive and the one very important, understand this. Tension the pre-bent wire with olive can cause a complex displacement of the fragment in two planes. Not only this, and not only this, it is the angle. And the angular deformation is the open deformation, and the support must be installed perpendicular to axis segment as the principal. But if it's installed in the angle, the assembly of the apparatus will result angular misalignment. If installed support to two fragments, we have a big deformation, and this, the longer the fragment, the greater displacement of the fragment. Angular deformation may be reconstruct the elimination deformation with the help of heat. And another variant is the traction of transverse elements. Or rotation is a more difficult problem. In this, we have the same placement subsystem, and we have the tightening rod when the tightening the nuts correct rotation or special device for it. This variance is the wire technique, but it's only works for free intermediate fragments. And they must understand the main goals with the capabilities of Ilizarov. We have many deformations and combination, and we use with traction elements or special device or the change the angles. And the one time we restore the ligament, the bone, and the position fracture. And the main goals for Ilizarov, be able to use them correctly. Thank you very much.
Thank you, Dr. Andrey.
Thank you, Frank.
Yeah, thank you, Andrey, for this informative talk. And actually, the pictures were very nice. With the picture depicting every point, there you have a picture for that. And I think it's very helpful for the viewers. Later on in the video also, when they will be seeing the pictures, they can understand a lot. Thanks a lot, sir. If anybody has any question.
No,
everyone has to unmute first. Unmute first, then only we can ask question.
Dr. Agrawal, you switch off microphone. No question. Thank you.
First unmute yourself. Akanksha, can you unmute everyone?
Yes, sir. Just a minute. I've just sent a request for everyone to unmute themselves, sir.
Yeah, okay.
Okay. Who is going to talk?
Yeah.
Agarwal, you want to talk first?
Yeah.
Okay, please.
Dr. Andrey, one thing I want to know, that in tibia you are using only the wires or sometimes half pins also? What do you think?
Sorry.
Да. Спрашивает, he's asking. Он вам задавил вопрос. Вы вот голен только используете спицы или пинсы тоже используете?
На голени. Да,
На голень.
Okay.
Yes.
Yeah. On this case, we used the wires and the screw rods, and screw rod on proximal, and the distal only wires, and the center only wires.
You never use the screw?
Screw in the proximal.
Yeah.
Of
The proximal sometimes the proximal.
Proximal, and we sometimes we use the half ring, and the two road screw.
Okay.
For the proximal, it's a good subsystem. It's good fixation, and if we used screw rods in proximal tibia, we don't use in proximal tibia the wires with Oliva,
Okay.
because it's very strong fixation, and the displaced for the wires and Oliva in proximal, it's not impossible.
And in the femur, in the proximal part, you are using the half pins. In the distal and middle part, you are using the wires or half pins.
In femur, we use only screw rods with proximal.
Yeah.
And yes, only. And my experience with the wires with the proximal is not so good. And my patient is not glad with the wires in the back. And we only rod. But in the distal, we use distal. We use the wires.
Wires in the middle.
Yes.
In the middle of the shaft.
Серединис. Андрей, говоря серединис.
And the center, it's the wires too.
Yes.
Wires too.
Yeah. You understood his answer, eh? Okay.
Yeah.
Sir, I have a question. In the middle of the femur and the tibia, especially in young adults, there can be a lot of thermal necrosis with the wires, but you still prefer wires in the middle of the tibia and the femur.
Барри, помоги.
Андрей, значит так, он говорит, что молодых, когда используется середины бедро, это некроз появляется, некроз костей и кожи. Это правильно или нет?
Это при спицах?
Yes, при спицах. В середине бедра. No.
It's maybe, but it's rarely the complication.
No.
If we use the wires and the good tension.
Yes.
Yes, it's very it's very important, the tension of the wire, and we can problems the diaphysis. We drilling the wires and the tensioning, But
Yes.
if you see on the wires, we can see this one part of wires, it's very thin, and another part it's not. Thanks. And because we can tension the wires and one part and another part too, because in diaphysis the wires is very good fixation into the bone.
Mm.
And we tension the wires only one side. Another side is not tension. And you can do this. After that, we can good tension the wires on all the supports. And we can, this problem is necrosis and other what, and the necrosis of the diaphysis may be the osseous necrosis. Diaphysis may be we drill the wires very fast, or maybe not the pause with the drill. With the 3 seconds, the pause, the 5 seconds, and the 3 seconds and 5 or 15 seconds the pause, because with the very big temperature on the wire, on the shepherding, and the bone after that is the yield, and we have big problem with the fish eyes after this, and maybe osteomyelitis, wire osteomyelitis, because with big temperature. I think this.
So can I add with Andrey?
Dr. Bari, can you explain?
Yes, yes.
Again?
This is the main thing is that we must, before applying the wires in the femur, it is very important the position of the femur. Most of the orthopedic surgeons, they put the Ilizarov wires in a straight way. You cannot do that. You must bend your knee to putting the wires. And proper tensioning of the wire is absolutely mandatory for femur fixation or tibia fixation in the middle and in the distal. In the middle and distal, what I learned from Kurgan, I using for the last long time. I don't use middle and distal the pins, only the wires. Proximally, due to anatomical constraint, it is better to go for pins. And during drilling, he told that, Andrey told that you must give pause for 3 seconds for every time. And if you go for faster drilling, you are creating the thermal necrosis of the whole bones. And if you see in Kurgan Center, the nurses, when the surgeons are doing the surgery, nurses are pouring all the time spirit to keep it cool. And that is his answer, what he's telling. Okay, thank you.
Okay, sir. And one thing he was telling
Thank you,
about,
Barry.
and one thing he was telling about the tensioning on the both sides.
Tensioning of the nerve, you fixed whenever you are, this is a normal way. Tension, striving force around the ring must be equal. You know, I don't know, my strength in the hand and Russian strength in the hand is not equal. Sometimes for hurry, they use with the Russian technique, but they are using also dynamometer. Before tensioning, you must block the one side and go for the another side. That's your state.
So one thing he was saying that
For special tension device is a very important instrument. And with the orthopedics operation, when we must long time apparat in the leg our patient. And very important with this device. But the trauma patient who take this apparat on the leg and the hand, the 1 or 2 months, it's not so important with this orthopedic.
Yeah.
So one thing, like how much tension do you recommend for adults and if anything in children, in femur and tibia?
Андрей,
Да, ну, как бы я понял.
сколько tension для взрослых и для вот этот children, взрослых и молодых или дети, сколько tension надо? Спрашивает.
If we speak about the method of the key for children is maybe one third the round, and for the adult it's the half. The half is the key. But in our practice, we haven't the special device with the measurement of the force, and this the control in the voice is the voice of the wires and the key, and bang bang. Да, Борис, скажи, что натяжение должно быть равномерным на всех спицах. И
Я сказал это.
Да, это самое главное. То есть это должно быть равномерным.
Very important, striving force around the ring must be equal to get good regenerate bone, he's telling. And сколько вы даете? 100, 90, 90, 90, 100 или 110 или 120? Спрашивает так.
Ну, как бы, натяжение на спицах. У детей просто сколько...
Barry, can I answer?
Yes, Professor Novikov, please.
Давайте.
This is depend of case. For example, this is baby or adult.
Baby or adult? Baby сколько, adult сколько, скажите.
This is sick or thin patient. This is big ring or small ring. Any patient have different forces for tension wire. For example, baby from 70 till 90, no more than 1000. I agree with Dr. Andrey. If this is adult patient, from 90 till 130, but this is very seldom. This is depend. Femur or tibia, big ring or small ring.
Yes.
And usually I use a device where I can control any kilograms. But how say Dr. Professor Andrey, we need to check each wire, and tension must be equal.
Yes.
Well,
Suppose
this is reason why, because with hand, any surgeon have different force in the hand. For example, with my age, my young assistant will usually, how I can say, if
No, Novikov.
ring and wire in same position, we need to give big forces. If we use wire washes and hinges and ring, forces will not big than on the ring, and on the end. Baby from 70 till 90 maximum, adult from 90 till 120, but absolutely different on the segment tibia, femur, forearm, and humerus. This is depend of case and depend of experience of doctor. Only one like musician, check stability of frame, and surgeon, when he apply all of frame with hand, I need check. This is stable or no? Как ты проверяешь, Барри?
Вот так.
С рукой обязательно.
See, tensioning of the wires is very important in Ilizarov surgery because we are using only the wires except the pins. In the tibia, I never use any pins, always with the wires. Striving force around the ring must be equal. I use dynamometer, see the 90 Faradal, 90 to 100, 110 Faradal. And it depends on if you are using the full ring, another tension. If you are using the 5/8 ring, another tension. If you are using the half ring, another tension. So it depends on case to case. And
You're
for
absolutely right.
correct? Am I correct?
Absolutely.
Yeah,
Okay.
you're absolutely right.
Okay, sir. Thank you. Thanks a lot. We thank Professor Andrew again for sparing his precious time and teaching us about the basics of Ilizarov. And let's go on with talk of Novikov. So I hand over to Akanksha to have a brief about Professor Novikov. Akanksha, please.
Good evening, sir. Good evening, everybody. I'll just share my screen, sir. So is my screen visible, sir?
Yeah, it's visible. Yes.
Okay, sir. So welcome, Dr. Novikov Konstantin. So sir has done his MD, PhD, and BSc from Russia, and he's a leading research doctor, traumatologist, and an orthopedic surgeon, mostly involved in pediatric orthopedic surgery with the Russian Ilizarov Scientific Center, that is in restorative traumatology and orthopedics at KURGAN. So basically, he has been given the title of MD for surgical lengthening of extremities in patients with low subjective and low growth by the method of controlled transosseous osteosynthesis. And he has authored over more than 190 scientific publications across the world and with over 45 interventions, along with his utility models, reaching more than 120 efficiency proposals. So sir has been a speaker at many major scientific conferences across Russia and in and around Russia in many Asian and European countries. Sir is available for a contact number on the given details. So with this, I would like to stop sharing my screen and ask Dr. Novikov to kindly take over. Thank you, sir.
Thank you, Akansha. Can I start?
Yes, please.
And dear colleagues, during my life, I use only one methods, Ilizarov methods. Different external fixator, internal fixator, but I'm use only Ilizarov methods, and just now I try my best to explain why. Like any methods, Ilizarov, sorry.
Sorry, your
You
voice
can see my presentation. or not?
Yes, visible,
Yeah, yes,
visible now.
yes.
Like any method of treatment, Ilizarov methods is accompanied. How I can say, Errores, this is our teacher, and impossible without Errores continue with our job, and impossible without Errores get experience in our job. But only one point: price of Errores. Like
Sir, your voice is breaking. in
if
between.
broken intramedullary nail or broken plate, patient will broken result. Patient will lose result. Patient will go to the very difficult way for treatment. And sometimes when we talk about Ilizarov methods, this is not same how doctor use external fixator, but this is not original Ilizarov fixator or absolutely different external fixator. And so many times when surgeon use original Ilizarov frame, but we cannot say this is Ilizarov methods. And very important follow rule of our teacher. Is it rule of Ilizarov? For example, this is doctor write down in the history correction of deformity with Ilizarov methods. I am not agree. This is not Ilizarov methods. But on the right side, this is absolutely different. External fixator from aluminium, but I think doctor can say this is Ilizarov method. And repeat again our method with complications and errors. And when we sometimes ask Ilizarov method, this is risky. Doctor, and this is the reason why, for example, in the Russia, so many doctor not want and against no one, because they say, oh, so many complications will come if we will start treat with Ilizarov apparatus. And in the literature, we can find different range from 0 to many hundreds % of complications. For example, 6% of complications. Dr. Craton from France talk about 150 sometimes, but usually this is data of complications, and I am very I want to say thank you very much for doctor from India, because this is not my slide, but why big difference between data? Because use of Ilizarov for variety of conditions, and at the present many different classifications of complications for a fixation device. For example, I prefer two applications from Safcot. and this is classifications, all events in osteosynthesis is initially considered as complications and divides them into categories with these classifications, because so many situations we cannot say this is complications. This is just now in front of I can say this is Russian classifications, but published from Paley, because we all time talk about problems from Ilizarov epoch, broken wire, common infections. We know today. This is information for me, for doctor. This is problem, but not complications. This is a problem, and doctor needs start treat with antibiotics, maybe remove this wire, but on the end of treatment, patient cannot remember play. I agree with classifications, Dr. Paley, problems, obstacles, and then only after that coming complications of complications. And we offer only those events that negative affected the final result of treatment to be a complications. And what is it? Errors, wrongness, inactions, didn't, judgments, those what is impossible to calculate and present. And advance based of accumulated knowledge. And we talk about complications not related to osteosynthesis, and we not talk about this and complications related of osteosynthesis. And I want to absolutely separate talk about objective and subjective factors and errors and complications. Errors and complications related of osteosynthesis.
Dr. Novikov.
By time of occurrence in the interest of organs and system. Oh, yeah.
Yeah, actually your voice is breaking. Can you switch off your video? I think it will be better. Switch off your video because your voice
just
is
a moment. And just now, you hearing me?
Yeah, we are getting in between, it's getting breaking.
You go on.
And what is it objective? This is situation not dependent on the doctor and the degree of dependent on the knowledge and skills of the doctor and his experience. And objective and subjective, when this must be weighed, we can say like a factor of the
Dr.
risk.
Novikov.
And very important.
Yeah, actually your voice is breaking. So if you can switch your own video, I think it will, the internet speed will increase. You can keep sharing the screen and keep saying, but you
I don't know what's happened.
No, you just switch your video off. It will be better. Your video. You can keep it off and you can just say.
And just now, you follow me?
Твою камеру просто попробуй отключить. Может, тогда звук пойдет лучше. Камеру отключи, чтобы лицо было не видно. Попробуй, короче, может быть, будет лучше со звуком. Звук прерывается.
Вот я сейчас... Сейчас ты меня слышишь, Андрей?
Да, я прекрасно.
Да, слышно. Я прекрасно слушаю, но ни проблема не будет. Они не слушают. Я слушаю прекрасно.
А видишь, Андрей?
Нет, я как бы презентация твоя видна. То, что ты выключил, сейчас может быть меньше расход будет трафика, и у тебя прерываться перестанет. У тебя потому что это самое видео идет, а то, что ты говоришь, не слышно, прерывается постоянно.
Ну вот это, да, такое бывает.
Да, поэтому отключи свой видео и продолжай. Все. Сейчас у тебя error devintent, что-то.
Да.
Вот. Все, как бы, давай.
Okay.
And just a principle. What I mean, when coming one problem, immediately after few seconds will come another. And for example, doctor, this is a patient from our department, run selected of patients, fat patients with negative psychological mind, then improper insertion of wires, and so many problems coming. Then obstacles, then coming complications. For example, when coming one problems, like you can see, insufficient number of pins, not stable fixation, wrong choice of ring and parts of the apparatus. But what is it? Just now, this is only a memory of pin track infections, but more than this place, and then only after solution of radiologist, infections finished with osteomyelitis. Another point, when doctor saw fracture, difficult fracture, but this is situation we can solve with so many plaster cast, like here. Doctor tries support with this patient with plaster cast, not so bad, but this doctor not satisfied. And try apply check with X-ray, and not satisfied with position of distal part of tibia, different place, not on the rule, not on the level of deformity on the fracture. Then biomechanical lines, center of hip joint, knee joint, and ankle joint, and satisfied with clinical examinations. But when checked by X-ray, so big deformity, and again hinge in other place, and with this hinge, doctor cannot support distal part on the normal position. This is all of mistakes on the part of doctor. This is subjective factor of doctor. We cannot say this is run of Ilizarov frame or Ilizarov methods. In other situation, this is end of treatment, big dislocations, and you can see hinges between the frame on the femur and tibia. Doctor put on wrong position, move knee joint. This is not Ilizarov mistakes. This is mistake of doctor. But again, this is mistake, errors, but not complications, including this is bad position of skin. Many months patients not come for checkup in front of doctors, and subjective factor of patients, because when we talk about result, we need to talk about both of part, not only the doctor. Patient too need to talk about side of patients. But here, this is not Ilizarov apparatus, but doctor says, lengthening, cosmetic lengthening by Ilizarov methods. And just now, colleagues, what you think? This is Ilizarov methods or no? During all of treatment, 6 months, patient not use leg, 6 months, stay in the bed. Doctor, you see, haven't hinge. And why this is so big procuratum on the, this is end of treatment. Patients cannot unbend knee joint, and doctor says this is complications of Ilizarov methods. Sorry, this is complications only from doctor side, subjective factor of doctor. Why? This is red line must be put proximal ring perpendicular of proximal segment of tibia. Again, you see this is big scars. Why this is scars coming? Because this is end of potential of soft tissue. And when only start, this is wire cut skin, doctor must think about maybe with wound will come another problem, will come infections, and you see during so many months not wash place of pins and wires, all of wires without tension. And not only procurvatum deformity and big valgus deformity. And with this frame, we cannot support with no near 6 centimeters of lengthening. Why during the lengthening, doctor not correct deformity step by step? All of these mistakes on the side of doctor. This is a final result. How patient will use a ballerina foot, valgus deformity, bend position of knee joint. I am not agree. This is fault of doctor, only of doctor. I talk about clinical results, but this patient must be have information about when coming some problem to the doctor, clean, put on of antiseptics, and give care at this place. 50-50 patient and doctor. Same. Same. Why? Because mistake of doctor, size of ring. But "24 hours patient stay in the bed." Again, show us patient without any activities. This is not Ilizarov methods, because our patient to just be stand up, walk, and change position in the bed. And now I want, and I must say, this is same responsible of doctor and patient. But patient during all of lengthening first time stand up, and this is ballerina foot, and patient and doctor says this is wrong of Ilizarov message. Sorry. And not walk. Even we immediately finished of lengthening. This is gold rule of these mistakes, not only from doctor and patient not follow our instruction, but why doctor continued lengthening with this position of foot. Yeah, this is complications of these complications, not Ilizarov methods. Must be found from doctor and patient. And very important, on noticing that treatment is not going fine, we should ask for help from experienced doctor, because we are not alone. And near with us, we have just now mobile. We can call Barry. We can call Arshad. We can call Novikov too. And so many doctors with experience can help. And our methods, almost how Ilizarov says, bloodless surgery. And our methods, this is firm fixation of both bone fragment, obligatory early weight bearing of the affected limb, and function of the adjustment joint. Post-operative adjustment of the bone fragments from the time of surgery till their removal of frame. And I want to add, what is it, Ilizarov methods? Most important, this is good rapport and understanding between the doctor and the patient. Our methods not for all of patients. Must be select patient. Colleagues, this is photo near 10 years ago when I was in Bangalore. I made this photo from India. Patient is happy, near the 10 centimeter lengthening, bifocal, fantastic, and patient's happy. But during the 1 year, this is patient not use the leg. Why doctor not check? Why patient not come? Why? So many questions without answer. Ballerina foot. Big swelling. So many, this is not complications from beginning. This is what was mistakes and the errors from beginning, but patient on the end. Same situation on beginning and on the end, big different. And why this is patient during 1 year not stand up? I think doctor not check, or patient, I cannot say she is stupid, but why she not follow instruction of doctor, patient, and on the end, very bad result. And who is wrong? Ilizarov methods or patient or doctor? Must be not compliance with Ilizarov principle is already a mistake, which inevitably leads to complications. And this is a girl listening by one level. Our doctor from our Ilizarov center in the Ukraine, he left from our institute with the good. He can lens, but please, doctor, 1,000 times think centimeters. This pretty girl won't increase height from 172 to 175. And she is winner of competition pretty girl, and on the end she has a good need be 175, and 3 centimeters she need increase height. The doctor was, oh, this is very quick. She will less than before. Her height, she has big scars, she has osteomyelitis, she has discrepancy. This is price of 3 centimeters lengthening. Why? Because from beginning, she and he, doctor and patient, not communicate, follow instruction of doctor. Doctor, okay, you not follow me, you can leave from me. Patient finished lengthening with herself, with support of doctor, and you can see her foot. This is wrong, both of doctor and patients. Ilizarov message is very bad because I have I lost my life. But this is mistake only of patient and doctor, and we cannot say this is complications from Ilizarov methods. This is my patients from Australia, and she has excellent complications. This is my complications because my surgery not give him improvement. I treat only his head, 13 centimeters lengthening, but I give him big disproportional. This is my pain. And just now, why? Because I follow interest of patient, and patient not understand some. Please, when you start increase height, calculate everything. And not follow because you see short femur and so long tibia, with good function of knee joint, both of feet. But for me, I can say this is heaviest complications. And you see, good rapport between doctor and patients when patients understand everything in other patient during lengthening. And she want so many centimeters, but I calculate her, please, no more than 3, 10. But we finished with optimal, with harmonic, proportional lengthening. And on the end was excellent, perfect result. This is our Congress Hall, Ilizarov. This is near 40 years ago. patients from German, you see bifocal lengthening, simultaneous tooth femur, and patient use sticks, not crutches. Epocha de Ilizarov, all patients walk, not use elevator. And I am happy when apparatus send Ilizarov message, and Ilizarov message say, I'm finished. Ilizarov message allow the doctor to correct the errors and prevent complications. And just now we can see during the legs lengthening, foot equinus deformity, the information for me. Maybe not enough exercise, maybe high speed of lengthening. But on the end, only one patient has complications and need some support like head surgery. All errors are subjective. Not all errors lead to complications. Very, very important. Errors are the precursors of complications. The errors is reversible. The complications has consequence, and very important. And on the end, all negative situation during the osteosynthesis are subjective. All negative situation are subjective. And I can say, you see, this is genius Antonio Stradivari. This is his baby, magic violin, but without magic hand of Nicola Paganini. This is piece of wood, nothing more. Another genius, our teacher, our father. Create magic apparatus. And without hand of surgeon, this is piece of metal. No one, even the most, is not free from erroneous mistakes and judgments. Not that person is smart, who does not make mistakes. The person
Dr. Novikov?
Good, correct.
Yeah.
Я улетел куда-то. Colleagues, you follow me?
Yes, yes.
The person is intelligent, who make mistakes and who knows how to easily and quickly correct them. And can we say, I want to congratulate all of us, because in our hand, fantastic, unique, and very much. And very sorry, I am a little bit late.
Dr. Novikov?
Thank you. Finish?
I am finished, yes. Thank you very much, colleagues. Thank you for your time.
So please stop your screen share.
Yes.
അതെ അതെ അയച്ചിട്ടുണ്ടോ നോക്കാൻ വാട്സാപ്പ്
Dr. Rajesh, shall I start?
Yeah, just a second. Thank you, Professor Novikov. I think we will take the advice from you that the mistakes are fine, but the most important thing is we correct it as quickly as possible, because that's what happens. As we apply Ilizarov and we see there is some errors or mistakes are going on, and if we neglect it, it leads to complications which has consequences. So this is very, very important that if we see any mistake, which will happen with everyone, we should discuss with our colleagues, with the patients, and we should rectify it as soon as possible so that no complications arise. Thank you, sir, for such a wonderful talk.
You're right.
Is there any, if anybody has any questions?
Yeah. Just I want to ask that how you can avoid to prevent the procurvatum and in tibial lengthening.
Please
Hello?
repeat again, because
In
I
tibial
listen only
lengthening,
a few words.
how we can prevent the procurvatum?
This is depend of number of wires. Just now we start for adult patients use half pins, but usually this is problem come after 5, 6, 7 centimeters of lengthening. Let me show, for example, this is soft tissue. This is a simple soft material and absolutely same situation. After 3-4 centimeters coming problem and coming situation when elastic potential of soft tissue muscle tenderness will show us. Maybe divide, for example, patient discrepancy. I prefer twice 4 and 4, and during maybe 10-15 years, I mean, procurvatum deformity. Just now, 3-4 wires for any adult or baby procurvatum deformity. And when coming procurvatum deformity, immediately we need or stop lengthening, or start corrections, or change wire. Sometimes patients not agree for second surgery. A few wires on the proximal part of tibia, and then continue to change position of proximal ring, continued and finished lengthening without any deformity. But why coming so many complications and obstacles? And then because any patients from beginning need big time, we need spend any x-rays, we need little bit change position of rate of lengthening, but usually if doctor ready for spend time, we can prevent complications.
Thank you, sir. And now let's go on with our next speaker, Professor Satish NESARI. Professor NESARI, please connect your talk.
Yes, sir. Good evening, everybody. I'm Dr. Satish NESARI. So I thank Asami India team for giving me opportunity to talk on corticotomy. So I'll be talking on definition, types, techniques, regenerate, problems of corticotomy, poor regenerate and its management, and some cases done by me. So before starting, I would like to emphasize that stable fixation is a must before going for a corticotomy. And we all know distraction causes distraction osteogenesis. But compression does not always produce osteogenesis, because if the fragment fixation is not proper, or you are compressing in a shear force or a displaced fragment, this can lead to a necrosis of the bone fragments and resorption of the bone. So compression does not always produce osteogenesis. And again, the osteogenesis depends upon the compressive load given and state of blood supply and quality of fixation. So corticotomy, also known as compactotomy, by definition, it is a cortical osteotomy with transection of the bone cortex, preserving periosteum and endosteum. And we also should know that there is something known as latency period. It's a period of time after corticotomy and starting of the distraction. So coming to the corticotomy types, transverse and longitudinal osteotomy, we have two types. And in transverse osteotomy, we have classical method, which has been mentioned in all the Ilizarov books, and multiple drill holes technique and a jiggly saw method. So as I said, stable frame is a prerequisite before proceeding to the corticotomy. So in classical method, after applying a stable fixator, the distraction, the connecting rods should be removed, and an incision is made on the shin of the tibia, and periosteum is elevated all around that is the lateral surface and the anteromedial surface of the proximal tibia, as is shown in the figure. The 5 mm or a 10 mm osteotome is taken, and you can see here only the cortex has been severed. So similarly, the anteromedial surface is also the periosteum is elevated, and corticotomy is used, and cortex is severed. And in this last right lower picture, you can see the hexagonal shaft of the osteotome. We use a 13 mm spanner and fix it onto the shaft of the osteotome and rotate in clockwise or anti-clockwise manner in order to disrupt the discontinuity of the cortex. So in this lateral view, you can see the osteotome has been rotated in order to weaken the posterior cortex. Once you have weakened the posterior cortex, both the proximal and the distal segment is held with the hand, and external rotation osteoclasis is done in order to break the posterior cortex. So in jiggly saw method, we have used a jiggly saw. We usually use a jiggly saw, which we usually use for amputation. So here an anterior incision is made over the shin, and another incision on the posteromedial aspect of the tibia. And jiggly saw is inserted as is shown in this picture, and gradually with saline pouring, the jiggly saw osteotomy is done. So we have a multiple drill holes method, which is commonly used, and I have learned it from my mentors. So here what we do, initial drill hole is made on the outer cortex. With the single drill hole with the multiple direction, the opposite cortex is weakened with multiple drill holes. And similar to 1 or 2 or 3 entry points are made, and the opposite cortex is weakened. With the help of an osteotome, we just connect the whatever drill holes we have made. We just connect them under the Shyam guidance. So this is one of the patient I have recorded. A 2 centimeter small incision is made. There is no periosteum stripping, only the muscles is separated. And we use, I personally use a 4.2 drill bit. And then under the Shyam guidance, I do an initial drill hole, and then with multiple directions. I weaken the opposite cortex as it is shown. You can see here I'm holding a saline soaked gauze piece. This will help me to stabilize the drill bit and avoids inadvertent piercing of the opposite cortex. So always you have to hold the drill bits firmly and drill the holes, not injuring the neurovascular structures. Now, with the help of a 5 mm or a 10 mm osteotome, I just connect the multiple drill holes which I have made. This has to be constantly monitored under CR just to prevent inadvertent piercing of the opposite cortex. You can see a nice linear corticotomy has been done. So how to confirm whether the osteotomy is complete or no? So here I have loosened the outer side of the nut, around 3 to 4 mm I have loosened, and then I'll ask my assistant to gradually give a distraction force, as you can see here. And once after this, I take a Shyam shoot and just see in the CR. So here you can see a nice distraction has been occurred, which indicate that my osteotomy is complete. So what is the basis? This is a preparation for a good regenerate to obtain. So osteogenic activity of a connective tissue is stimulated by tension stress when tissue is stabilized. So again, I am emphasizing stabilization of the frame is very important. So quality of new bone formed depends upon distraction force, cross-sectional area of the distracted region, rate and rhythm. And at the end of distraction, once you have obtained adequate distraction, once you stop, the connective tissue is automatically replaced by a good bone. For a successful regeneration of a bone to occur, axial loading of bone, that is patient has to walk, and a good blood supply and good muscle activities required. So conventionally, in all the books we read, rate of distraction is 1 mm per day, and 4 times frequency of distraction is applied, and a latent period is 1 week. This is to allow recanalization and revascularization of injured bone marrow vessels, which is done during the corticotomy. So coming to the blood flow in the bone, which this is very important as far as corticotomy is considered. We have in a bone, we have centripetal blood flow, where the blood enters the bone from the periosteum vessels and comes out from the nutrient vein. Whereas in centrifugal flow, blood enters the nutrient artery, bone through the nutrient artery and comes out from the periosteal venules. So when we do a periosteal stripping, this divides blood supply to the outer third of the cortex. So when we do an osteotomy, suppose if we damage the nutrient artery, it divides the inner 2/3 of the cortex. So always, we have to, while doing a corticotomy, avoid damage to the nutrient artery and avoid extensive periosteal stripping. So when we do a corticotomy, there is some damage to the periosteum as well as endosteum. So how this is compensated by increase in metaphyseal blood supply by means of whatever we have seen, centripetal and centrifugal blood flow. So there is increase in metaphyseal blood vessels and the blood supply is restored. So to obtain a good regenerate, less damage to periosteum and bone marrow and less comminution. If at all comminution occur, it should not be displaced too much. So this is the crux to get a good regenerate. So an ideal osteotomy is a long oblique osteotomy, should be in the metaphysis without comminution and should be a closed osteotomy. Why it is done in metaphysis? Because the bone is wide and cancellous, wide cross-sectional area, nutrient artery can be preserved, and origin and insertion of muscles already have been adapted for extremity growth. So when to avoid corticotomy? So avoid in old scars, and whenever there is infection, you can wait for a week, 10 days or a month. So not, and to avoid the corticotomy in zone of sclerosis and severe osteoporosis, and whenever there is cyst formation, you should avoid a corticotomy. So what type of regenerate we can get? We can get a normotropic regeneration, hypertrophic regeneration, and a hypotropic regeneration. So there are so many factors which affect a good regenerate. Patient factors, local factors, technical factors, and biomechanical factors. Some of the factors are under our surgeon control, and some of them are out of our control. So coming to the cases, this patient presented to me with osteomyelitis, growth arrest in a 16-year-old boy with 15 centimeter shortening of the right femur. So for this patient, since there was an infection running on, first process was control of the infection, and second is the union. So once in 2 months, everything got controlled, fracture united, the non-union united. So I proceeded with the lengthening process. So I could achieve a good 12.5 centimeters regenerate. And here you can see the bone, the limb length has been discrimination that is equalized. So this is at the end of 13 months, the bone is nicely united, and the patient is walking nicely and is back to his college. This is another case with a 4 centimeter defect which occurred following a debridement of an open fracture, where the surgeon has treated with plate and screws. There was necrosis of the skin and infection was there. So I had to excise the 4 centimeter dead bone. And since there was a little persistent infection, I waited for corticotomy for about 10 to 12 days. And then later, once it was confirmed that infection was absent, then I did a corticotomy. And as you can see, early weight bearing, axial loading, muscle action, and a good blood supply is a key to get a good regenerate. And this patient immediately started weight bearing, and patient had a stable, painless frame. So this is at the end of 5 months, the fracture united, a good regenerate was consolidated, and he's a priest in a temple, and he is back to his work now. This is another patient in a polio limb. The patient had a osteomyelitis of the tibia, and in this patient, I had to excise the necrosed bone, and I did a proximal corticotomy. In polio bone, since the musculature is less, we have to wait. The latent period has to be increased, not for 7 days. You may have to wait for 10 days or 12 days. And then start the rhythm also, we have to slow down, maybe 0.25 mm BD or TID, and then gradually start the distraction. So this is at the end of 6 months, a good regenerate was obtained and the bone nicely healed. And this is how the patient comfortably walking with painless, near normal gait. So this is another patient where I did a bifocal, very long bone transport. This patient had a comminuted type 3C fracture with multiple fragments. So I had to excise the necrotic bone fragments. And here you can see I did a distal corticotomy because there was no place proximally. So distal tibia is a very interesting area. As we know, there is a less blood supply. Why there is less blood supply? If you see the nutrient artery supplied to the tibia, it enters into the diaphysis through the middle of the bone and divides into only one descending and 2 ascending arteries, as you can see in this picture. So only one nutrient vessel in the lower third of tibia, less periosteal blood supply, and decreased muscle bulk. These all factors helps means the infection and the non-union are more common. So in such cases, when you do a lower tibia osteotomy, you have to increase the latent period from 7 to 10 days and also decrease the rate and rhythm of distraction accordingly. So in this patient, I started with a 0.25 millimeter twice a day. And then as I saw the good regenerate, I increased it to 4 times. And then at the end of, so at the docking side, there was a problem with skin invagination, which I dealt with the excision of the skin and added a little bone graft. At the end of 15 months, I could get a good 16 centimeters long, good quality regenerate. And so another patient, trifocal bone transport has been done. Plastic surgeon did a flap. Sometimes flap interferes with our work. So this patient, the surgeon did a flap surgery, but the bone ends were not proper and were unhealthy in the X-ray. So I had to excise the bone graft, bone ends. So it came to about 5 inches of shortening after debridement. Then I did a trifocal bone transport by Ilizarov, did a 2 osteotomy, 1 above and 2 below. In between, he had some infection. I had to exchange wires and add a stimulant antibiotic beads at the docking site. So this is very important because always stability of the frame is very important to get a good regenerate. So if you come across any infected wires, never hesitate to replace them. So this is at the end of 11 months, a good regenerate has been formed and union has been achieved and patient is back to his agriculture work. Another patient, trifocal bone transport has been done. Patient had a polytrauma with head injury and patient had subdural hematoma for which craniotomy had been done. So in this process, the tibia was neglected and so tibia went for a necrosis, 18 centimeter necrosis. So I had to excise the 18 centimeter dead bone. By the time the patient presented to me, patient was bedridden and was not able to sit up and very non-compliant patient. I hesitated to apply Ilizarov in this patient. Many of the surgeons had advised amputation for him, but his father asked me to salvage the limb. So I proceeded with good hope to salvage the limb. I excised the 18 centimeter dead bone. And here you can see the distal tibia. There is a scar and a wound is there. Never do an osteotomy when such condition is there. Always wait for 10 days, 15 days, 1 month to heal the wound to heal and then go for an osteotomy. So in this patient, I did a trifocal bone transport with 2 osteotomies and gradually distracted. So this is after the completion of the completion of the transport. So in this patient, when I excised the 18 centimeter bone, I did not do any flap. No flap surgery is required. Once I started the corticotomy, wound started shrinking in size. So by the time I could achieve a docking site, there was a good covering of the skin, except there was some raw area, which I did manage by doing a skin grafting. So this is at the end of frame removal, a good regenerate has been obtained and the wound raw area skin grafting was done. In order to protect the regenerate, I gave him a ankle foot orthosis in order to just to protect the regenerate. And corticotomy in a deformity correction is also useful. It is useful in deformity correction also. You can see this patient has a grotesque lower end femur deformity. So I had to plan with a graphical method and then mounted Ilizarov frame. You can see an oblique osteotomy has been done in the lower end of the femur. The rings were so close, had little bit difficulty in doing a corticotomy, but I could do a very good work here. And then here 1 mm per day will not work. You have to always use a rule of triangle here. So with this, you have to calculate AD by AB formula. You have to calculate the rate of destruction of the motor rod. So when we calculated it, it came to about 2.85 millimeter. So I had to distract 2 mm 4 times a day in order to prevent premature consolidation. So this is the patient moving after the correction. So longitudinal osteotomy, also known as TTT, as said by Bari sir. So here we do a osteotomy on the anteromedial aspect of the proximal tibia. So by doing this, increase the vascularity of the limb to 300%. Greater the surface of corticotomy, more pronounced is the regenerate. So my way of doing the osteotomy, what my mentor has taught, I make a skin incision, multiple skin incision on the anteromedial aspect, weaken the anteromedial border of the tibia with multiple drill holes, and then with the help of osteotomes, 4 to 5 osteotomes, I just connect the multiple drill holes in this manner. As you can see here, the osteotomes have been inserted into the drill holes, and like a flap, I just break the bone, which has to be confirmed under the C-arm, and then the broken flap is fixed with the multiple K wires, cross K wires like this, and then gradually distracted. So this is a patient with presented to me with gangrene right toe, with a TAO and block at the popliteal artery level. For this patient, I did a longitudinal osteotomy and then fixed with and then at the end of 6 months, you can see a nice healed vascular limb, and a good regenerate has been consolidated. And we can do it for TAO of the upper limb also. This patient presented with me with a gangrene of the thumb and the index finger with block at the brachial artery level. So I did a osteotomy of the ulna and then gradually distracted. So here it's a simple method. We make multiple drill holes in the ulna and then connect with an osteotome and then fixed with multiple. At the end of 3 months, a good consolidation has occurred. And sometimes premature consolidation is very common in young patients, and so a rate of distraction 1 mm per day will not help. So in this patient presented to me for lengthening and varicization, pelvic supporting osteotomy has been done elsewhere with a plate. So I did it with a LRS, but there was a premature consolidation, and I had to do a repeat corticotomy through the substance of the regenerate. And then this is the picture. I could get a varicization as well as little lengthening of the femur. Sometimes while using the multiple drill method, drill can get broke and get embedded into the medullary cavity. So do not get panic. Do not meddle with the medullary cavity and periosteum much. Do not try to open. Just leave it like that. With minimal intervention, if you can retrieve the broken drill bit, well and good. If you cannot, just leave it like that. This is an example to show that if you leave the drill bit, nothing will happen. A good regenerate has still been able to obtain with even the broken drill bit. So every time we need to reduce the distraction sometimes. So in case of severe pain, you have to reduce the distraction or sometimes stop the distraction. And if you encounter any neurovascular problems or a poor regenerate, you may have to reduce or sometimes stop it. What are the causes for poor regenerate? So decreased mobility of the patient, decreased stability of frame, poor nutrition, and decreased vascularity. These are the main causes. Sometimes if we come across poor regenerate, you can always try a accordion maneuver, 2 cycles, starting with the compression and distraction. 2 cycles you can try in order to get a good regenerate. This is I can say a failure of mine. with a poor region rate. This is a doctor. Doctors are very poor patients. He's a homeopathy doctor. He sustained a road traffic accident and sustained femur and tibia fracture. Both were open fracture. You can see here in this X-ray. This is the initial X-ray. He had a necrosis of the lower end of the tibia. So what the surgeon did was did a flap surgery on the necrosed bone. Later, it got infected. Patient underwent multiple surgeries. During this process, the patient went into severe depression. So cross-leg flap, something like this, with both the leg in this position for 6 weeks to 2 months, is a torture, mental torture to the patient. With this treatment, patient went for a severe depression and became addicted to the drugs. He is also a known case of hypothyroidism. So there were so many multiple factors involved.
Dr. NESARI,
Yes.
can we please hurry up because we have case presentations also.
Okay. So this patient, I had to excise the necrosed fragment, and in between he had cellulitis. But at the end, because of severe suicidal tendencies, I had to remove the frame. And this is the last picture where there is a poor region rate and a persistent non-union lower down. So this is another patient. Okay. To conclude, a stable frame is a prerequisite, and a good corticotomy is a celestial weapon in the armamentarium of an orthopedic surgeon and saves you from all kind of problems. Thank you.
Thank you, Dr. NESARI, for showing the wonderful cases and the corticotomy technique. You have quite excellent cases with so much of lengthening. So it's pretty an eye-opener. So what can be done with an Ilizarov? So if anybody has some quick questions, we can have it. One thing to Dr. Bari and Dr. Novikov, suppose in a corticotomy, so does fine. Dr. Dr.
Don't. I can't listen. Please repeat it again.
Yeah, suppose a surgeon is doing a corticotomy and a combination occurs.
Dr.
So does the
Rajat,
surgeon has to vary anything?
we lost your voice.
Yes.
Yeah.
Sometimes if you do a traumatic corticotomy, that means traumatic corticotomy, you have done more than 2 or 3 fragments. Okay, this is the question?
Yeah, yes.
Yes. When you are doing the traumatic corticotomy, you can wait for 10 days. See, for adult, I don't wait for 7 days. What Satish NESARI, he told, nice lecture, it was a good lecture. 2 things, observation. For adults, I go for 5 to 6 days maximum. For children, below 5, I have done the corticotomy today. Next day, I start lengthening. This is a pediatric periosteum, is very thick. If you wait for 2 or 3 days, that is not good. It will regenerate quickly. This is number 1. Number 2, when you have an infection, see, Professor Ilizarov theory, to eliminate infection, vascularization of the osteomyelitic center or infected center is increased by the biological stimulation of corticotomy. Even in infected area, I have a book written in Russian. I have taken from there, and I have seen I go for corticotomy in infected area too. I don't wait. You can wait. That is another thing. 7 days, 2 weeks, or 3 weeks before you wait. But to eliminate infection, in the same time, you have infected bone in the ear, you can go for lengthening. You don't need to go for even in unifocal or bifocal or by trifocal. These are I'm doing all the time. I'm getting good results. And in most of the cases in Satish NESARI, he has fantastically shown, but In many cases, I've seen in tibia and femur, all with the pins. Truly say, this is not the KURGAN pattern Ilizarov. Whenever fundamental principle of Ilizarov methodology is load and motion. Yes, you can give load and motion with the pins, but you need to know the three things. The properties of the bones are isoelastic, hydrostatic, and pneumatic. Whenever you are putting the multiple K wires, you are giving your patient jumping and working. Last slide, you see Professor Novikov has shown the exercises. And with the most of the orthopedic surgeons, after putting the Ilizarov, don't go for any exercise, don't suggest the patient. You please, today you have done the operation, next day you start your working with the Ilizarov apparatus. I still remember when 25 years back, 22 years back, I met with the Professor Shyam. So first talk when he saw me, our task is movement, movement, and movement. And Ilizarov methodology, whenever you put this properly, you should have to start movement. This is the principles of Ilizarov. Otherwise, all you are doing hybrid. This is not the KURGAN pattern. You can do that, but you are violating the rules of the principles of Ilizarov that Professor Novikov showed you in different varieties of cases. Thank you very much.
Thank you, sir. So one question, because it's a controversial question, whether to do a corticotomy in an infected area or when there is an active infection. So we would like to hear the opinion of Dr. Andrey and Dr. Novikov also, what they do. If there is an active infection, will you be going for an osteotomy right then? Professor Novikov, can you hear us?
Very easy and very difficult questions, because in our center we have a special department. First of step, in infection department, doctor did procedure for remove and closed infections, and then start procedure with lengthening, with corrections, and etc. And I work in clean department. And I have one question for Dr. NESARI. On beginning, I was to say thank you very much for your excellent experience. Is, do you have information, data, your number of difficulties and complications depends of time of treatment? For example, if your bone transport finished during 5 months, this is one data of complications. If you finished bone transport during 10 months, absolutely another data of complications. Is your recommendations for minimized of complications? How we can prevent big number of complications and difficulties? And you are happy, doctor, because so many results with perfect regenerations with big special treatment, pills, herbs, because after 8-10 centimeters, usually we have not so good regenerations. Your result is perfect. Please answer me.
Thank you, sir. Thanks for the compliments. As such, I don't have any data because I am working alone here. So definitely, henceforth, I will definitely work on it. And actually, all of my patients, they are in contact with me. I can work on this data and get back to you, sir.
Okay, Thank you, Dr. Nesri again. Let's start with the case presentation. Akanksha, will you connect the slides?
Good evening, Dr. Novik. Dr. Rajat, I have a question to Dr.
Yes, sir, please.
Dr. Novikov. Actually, I'm Dr. Prasad. Actually, your case are very good complications you have shown, and the final message is very good. But in one case, the application of the proximal ring you have showed with a marker that it should have been applied in that direction. But what I feel in that is you might have applied in the same direction of what you have meant, your red line marking. But gradually he has lost his control on the proximal segment and it has been deviated because it was a bone transport. The corticotomy was done initially, but the proximal segment has gone in procurvatum deformity. That means he has not applied the ring in a wrong way, but the ring, the stability of the ring is less. That's why it has gone for a procurvatum deformity. What I feel is that rather than application of the ring is wrong, the stability of the ring is less. And it has gone for a procurvatum deformity.
International webinar. Voice message.
Hello.
Dr. Novikov, internet connection is weak. So let's, meanwhile, let's start with the case presentation. Aradhana, can you start with your case? Aradhana, you are mute.
I will start my case presentation.
Yeah, let's have one case from each of our presenters.
Yes, sir. Sir, is my slides visible?
Aradhana, your connection is weak.
Ma'am, it's better if you just switch on your audio so that we can optimize the usage of data.
My
Okay, meanwhile, Aradhana, you get your net connected. Can we ask Dr. Sheshgiri to start his case presentation?
Yes, sir, I am ready.
Yeah, please, sir. Please share your
able to hear me, sir?
Yes, yes.
Yeah. Good evening, everyone, and all the esteemed speakers. It's an honor for me to present in this platform. My cases are there. The interesting cases. I have only 3 and very short of lengthening of forearm and deformity correction. It's a case series. So I am Dr. Sheshgiri. I work here in JSS Medical College as associate professor, and I have done my Asami fellowship under Dr. Kirianko in China and Italy. So this is my case 1. This is a case of infected non-Indian. Someone had operated and they had put a plate and it became infected. They removed it and this case went into osteomyelitis. They put antibiotic beads. Again, they removed it. And when it came back to me, this was the picture on the right side. So what we did was we did a thorough debridement and we did a corticotomy lengthening, planned corticotomy lengthening for the radius. And we put an ulnar spacer using an antibiotic bead, which mimic like an ulna to give the support and the length of the ulna. And we started the corticotomy, and this is what happened. And next, the lengthening continued it went about 7 centimeter. And meanwhile, we loaded the patient using a chair, and I taught him all the exercises. This was a very extremely compliant patient. And this went on, and we did ulnar graft to shorten the time for his Ilizarov time, and we kept the ring on to give micro compression. And at the end, this was the union, and we removed the wire as well. The patient is very happy, and he could lift his chair and do and show us this post-exit Ilizarov implant removal. So this was a wonderful case. And I had another short case. This was a kid who came with epiphyseal deformity. It was a traumatic injury. Someone had put a K wire and it had gone for a physeal arrest. There was too much ulna variance. It was too long. So we took him for Ilizarov, and we did a corticotomy lengthening for this kid too. And this is the corticotomy site. We lengthened about 6 centimeter. And as I said, I usually load the patient, make him work, do weightlifting. And this was the callus what we got. And this was the time of implant removal. So if you see here, we have lengthened about 6 centimeter of the ulna. We have deliberately kept the ulna a little short because the physis was not yet fused. And this was the end result of this patient. The last case, what I have is case 3, where it was same, like it was an infected non-union with lot of infection, both bones. This was about 6 centimeter radius and 7 to 7 centimeter ulna defect. So then we went on to did a corticotomy for, we did debridement, put an antibiotic spacer, which I usually do if I see that there is a lot of infection. And then we take them after the infection is controlled for about 6 weeks. I do the ESR and CRP and see that if it is normal, we take him and do a corticotomy. And we do lengthening. This was the lengthening, and this was very good callus. And that as to shorten the time, we do a free fibula ulnar graft. This is the patient, and we keep the ring on so that we can do compression. And I load them axially for all these patients so that they can do. And this is the end result. They can lift a chair, and this was the end result. She's due for implant removal. We have kept it a little longer because I wanted to have a very hard callus so that I can do the implant exit. But if you see critically, the ulna is united, the free fibula is united, the lengthening is achieved. Here also the docking side, there's a very good union of the radius. So this is my short experience with, I have more cases, but since it's out of time. So I thank everyone, Dr. Nikki Gao, Shetso sir, and my mentor, Dr. Harshad Shah, Bari sir, so many people who helped me to do all this. Thank you very much. If you have any comments for me.
Yeah, please stop your screen sharing, Dr.
Yes,
Shah.
sir. Yes, sir. So how to stop? Yes, sir.
Good comment.
You have to click stop sharing.
I did, sir. I did.
Well,
I did, sir.
thank you. Thank you. Thank you. Thank you. Very
Hey,
good.
actually, your slide is still here.
Okay, sir. I don't know what to do.
Long time showing is good.
Stop sharing. So that's it.
Post cannot share.
So how it saves only resume sharing. Stop sharing.
Akansha, can you help?
Akansha can share. Stop.
Yes, sir. So good evening, sir. Sir, actually at the top you will find a green and a brown color bar. At the bottom of which there will be a red color small tab which says stop share.
Right.
Yeah, okay.
Done.
So finally got it. Okay. So let's have first case presentations of everyone, then we can have a discussion. So Aradhana, are you ready?
Yes, sir, I am ready. I will
Please.
start sharing the.
Yeah.
Now, is it visible, sir?
Yes, ma'am.
Yes. Yes.
Yeah. Excellent. Okay, I will go through my case quickly because of lack of time. Yeah. I am okay. 25-year-old female. She presented to me with swelling and inability to walk with discharging sinuses around the ankle. She was a case of hereditary sensory motor neuropathy, and monofilament test was absent from the upper third of leg downwards up to the foot. So here in the X-ray, we can see there is almost fragmentation of the talus, which was going on, and hardly any remnants of talus can be seen. and upper part of calcaneum also is almost fragmented, and it was a case of infected Charcot's arthropathy.